Assalamu alaikum and very good evening, everybody. I'm your host, Saima Asgar, Director, ISAP Pakistan Chapter. I'm also serving at M. Ejna Foundation and New Life Rehab Center, Sialkot. And uh, and welcome you all into this live session on a very important topic, crisis intervention and substance use disorder. From ISA Pakistan chapters, Facebook pages, and YouTube channels and Twitter. You can also join us from ISA Pakistan chapters official Facebook group and Colombo Plan Pakistan's Facebook group as well. And welcome you all into this live session. You can join us from ISA Pakistan chapters and Facebook pages, YouTube channels. And now, as before we start our live session, as many of you know that we specifically organizing these live session from ISA Pakistan chapters, Facebook pages and YouTube channels and Twitter as well. And it's very important to share what about ISAP. ISSUP is basically an international society of substance use professionals, which really focuses on the development, support, and representation of professional workforce in substance use treatment, prevention, and recovery field as well. ISAP Pakistan is a national chapter of ISAP Global, and right now 24 national chapters has been established under the umbrella of ISAP Global, and it has estimated at 17,000 members around the globe. And for more information and detail, you can visit us the issup.net for more information. I would also like to share that ISAP is an approved training provider by Colombo Plan Drug Advisory Program. But as you know that because of COVID-19, there was not possible to conduct on face-to-face training programs, conferences, or seminars. So, ASA Pakistan chapter Youth and Youth Forum Pakistan took this initiative to conduct online training sessions by inviting different experts who are having experience in substance use prevention and treatment field. So that's why we are here today with a very important topic, crisis intervention and substance use disorder. And before without waiting anymore, I would like to introduce our very important, very special and honorable speaker guest. It's difficult to pronounce her complete name, but I will like to share that her short name, Miss Claire Abbas from Philippines. She is He is fondly referred a registered psychologist in Philippines. He has an international certified addiction professional, clinical level 2. Her continued work in addiction field further earned her a master's in addiction counseling, credentialed and certificate granted by National Association and Alcohol and Drugs Counselors, United States of America. He is likewise a global master trainer of Colombo Plan Drug Advisory Program and a global drug demand reduction master trainer by UNODC. At present, she is an affiliate of St. Luke's Medical Center Global City as a practicing psychologist for adult clients doing individual marital counseling and psychotherapy, addiction counseling for outpatients, including psychological assessment as well. Additionally, she is also a consultant psychologist at a Total Care Institute Village and a facility for drug rehabilitation and behavioral disorders, and the One Algon Academy and the One Algon Academy, a mental health facility. In the past, she has been to Pakistan through a Colombo Plan and UNODC to conduct training programs on the basic treatment curriculums and the refresher course as well. And we are very glad and excited to welcome our very special speaker guest, Miss Claire Abbas. Hi, good evening. Hi, good.
Thank you for the.
And yes.
Hi, good evening, Saima.
Thank you.
Saima. Yeah.
It's all right. I would also like to mention that we first time met in Jakarta. That was 2010 in an international recovery symposium, and I would also honored to share that he is very good friend of us, and not only a strong professional background to work in substance use treatment, prevention, and counseling field as well, but most of the time we are requesting her to share your knowledge and experience with our Pakistani friends, and as many of you know that she is very familiar in Pakistan. Even when we shared our flyer to post on Facebook and other social media, many of you knows with that, wow, she's our master, she's our trainer, she's our mentor, and we will definitely fix our time to learn from her during this live session. So we are also feeling honored, and Mr. Aslam is saying that he is our 100 years old friend.
Yeah. Oh, thank you, Saima and Mr. Aslam. And well, you are my friends, my best friends in Pakistan. And it's always been a pleasure to be with you when I was there twice 2015 and another one in 2019. So I mean, it has always been a pleasure to visit your beautiful country and very warm people, and to also be with you guys, trainers and ISAP. Now you have your ISAP Pakistan. You are able to successfully organize it, and I'd like to congratulate you for your work doing continuing education for your country. This is a very good platform for the local Pakistani addiction professionals. I believe has so many now. Are you hundreds already?
Thank you. Thank you very much.
And Mr. Aslam would always, Aslam and Saima would always insist on seeing me there. Sometimes I feel so shy already. So also I always find it a joy to be with with the co-trainers, Pakistani co-trainers there in Pakistan.
Thank you very much. Thank you very much for your wonderful remarks. Before we start our proper session, I would like to welcome all our viewers and who joined us and who are joining us later. And on behalf of ISA Pakistan and Youth Forum Pakistan, even from all the Pakistan, I would like to welcome once again Miss Claire Abbas. And now I would like to hand it over this session, which is a very important and unique topic, crisis intervention and substance use disorder, to please continue this session. And also request our audience, if you want to ask any question, you can send us regarding this topic. You can send us in the chat box, like comment box as well. So later on, after finishing the presentation, we will take some of your questions and request our speaker guest to answer your question, please. No, Miss Clara, please continue the session. Thank you.
Thank you, Miss Saima, for the kind words. I also would like to greet the Philippine audience, of whom I hope they'll be listening also. And who's also been listening to the YouTube, Facebook Live that I also had in the Philippines. And and I always find it a joy to share what I have been doing for the past several years in my work in the therapeutic community. And now I'm doing outpatient in hospital setting. There are so many things. I mean, our work in the addiction field is quite, wide, and it has gone to a large extent of developing, learning, sharing, and now globally, which is
Thank you.
quite exciting. Okay. For this evening, I particularly chose this topic, crisis intervention. Maybe because we are in the pandemic because of the COVID-19, and a lot of the webinars had something to do with substance use disorder and COVID-19, and most of it was like about crisis management. Uh, Crisis management talks about organization, a group, a large group of corporations, and other large groups of people. But for crisis intervention, we're going to deal with individual crisis of the person in recovery. So that's the focus of my topic. Can we have the first slide, please?
Sure.
First slide, please. So crisis intervention and substance abuse disorder in the context of recovery. So that's why I was saying that the general objective of this presentation is to share knowledge and experience in the conduct of crisis intervention and to apply those that are relevant in SUD recovery. To achieve this, I will discuss some basic knowledge and discuss crisis intervention as it connects to the SUD recovery at different levels of care. So when we say different levels of care, we're talking about the continuing care wherein client is, navigating. Next slide, please. There. This is it. So that's my focus, knowledge in the conduct of crisis intervention, and to apply those that are relevant in substance use recovery. Next, please. Here is the data from the Substance Abuse Mental Health Services Administration in US. You notice here, this is the admission to a mental health facility. It says here that 1 in 10 people who are discharged from this facility and discharged back to the mainstream, 1 in 10 is likely to be readmitted in 30 days. The lower level picture, again, admissions in a psychiatric or a mental health facility, when they are discharged, 1 in 5 is likely to be readmitted within the 180 days, meaning within 6 months. So this picture, this slide only says that it seems like it's better to stay longer in treatment so that you have a very good chance of recovery. But it doesn't mean that you will not be experiencing any kind of crisis in your journey to full recovery. Next slide, please. I would like to, can we go back to that slide, please? Sorry. Okay. No. Go back. Go back. Okay. So this is a person in crisis. Let's just assume that SUD, substance use disorder, crisis, and suicidality. People with SUD in treatment have high risk for suicidal behavior and other negative behaviors, examples, self-harming behaviors, especially in the early recovery or even during detoxification. Why is that? Maybe you'll ask, why is that? One is most of them enter treatment because of a crisis. They became out of control of their addiction, which make them depressed and feel hopeless, maybe because of shame. And they're usually at their lowest point, and they need to be readmitted because we need to save their lives. Some people die because of too much use of drugs. Or they expose themselves unnecessarily to risky situations. Another reason is that some of our SUD have mental health problems prior to addiction that were undiagnosed. And then when they engage in addiction, this becomes co-occurring disorder. And we know very well that the risk for relapse and recurrence of drug use and recurrence of mental illness is quite high among this population group. Now there are also crises that are known to increase suicide risk in early recovery, which sometimes occur during treatment transitions. For example, from detox to the inpatient, detox hospital, and then to inpatient rehab facility. That transition sometimes can affect their recovery in the sense that, hey, this is the real thing. I have to deal with my problem that has been lagging behind for so many years now. And it is the first time that they enter treatment. And now suddenly they don't have the drugs that they've been holding on, that been keeping them numb from all their problems in life. And now they have to face the truth about their life. And it's so shameful, and it may cause them to feel depressed. And then another one is that most of our clients enter treatment. Most of them have high levels of depressive symptoms. Usually, if you're in the use of methamphetamines, and when you don't have access to these drugs, usually we know very well that you will have very high levels of depression. So now, if that happens, therefore, our client in early recovery will have all sorts of crises. Let us define what crisis is. Crisis presents an obstacle or trauma or threat which may temporarily cause distress to a person. This definition talks about general crisis in life, whether you have SUD or not. But ordinarily, people experience crisis in life. But most of us are able to bounce back easily, probably because we have very good coping mechanisms. No? In mental health terms, a crisis does not always refer to a traumatic event. It can also be a person's reaction to a stressful event. And that a crisis in one person may be a crisis to another person. And why is that? Crisis can likewise be, next slide please. Next slide please. Crisis can also be an opportunity for growth. In SUD recovery, if one cope well, client gains confidence in dealing with the daily stress of life in recovery. When someone is in recovery, I mean, just dealing with the business of, taking good care of himself seems to be quite difficult because they're so used to life outside that there are no rules, there are no structure, and now they are into facing the realities of someone being, helped to make a change in his life and do better. So some take it as an opportunity, some don't. Some just decline into what deteriorate. Their lives become more miserable. So next slide, please. Next slide. So it is like a plant, no? When you plant something, it grows. So a crisis can also be like a plant. It can also be an opportunity for growth and self-discovery. So, what I'm trying to say is, crisis is part of life, and we might have to just do our best to be able to bounce back from all our crises. But sad thing is, people with mental health issues and with the problem with SUD may find it difficult to do so. Next slide, please. This is a picture of someone who is in a crisis situation. We know very well that crisis can occur without any warning. Just like the COVID-19, we were caught. Uh, all of us, our roles became upside down because of the sudden news about COVID-19. And it's really something that unsettles everybody. But for somebody in recovery, this is quite really difficult. It tends to occur suddenly, leaving the individual helpless and unable to respond, which may render a person's functionality less, or if it continues, it may result to chronic stress within a 6-week period. The length of time for a crisis to exist. No, beyond that, we need to do more intervention. So, in the absence of any intervention, person is likely to develop what we call PTSD or post-trauma stress disorder. Beyond this period of risk of developing, PTSD is likely. Again, all depends on the individual's coping resources and support network. At this point, problem solving is quite critical. So, can we go to the next slide? Next slide, please. So in here, I've listed some crisis situation wherein people, encounter every day. But for our SUD in recovery, they have different crisis situations to, deal with, no? Like situational crisis, which refers to just simple as job loss, can be very stressful for them, especially if they have a family. Nowadays, financial reversal for the parents of those in recovery, just hearing the news will really make them feel depressed. Who will pay for my fees? Who will support me? That's happening in the Philippines also in our centers because there are no jobs during this period of COVID. No. Now, another situational crisis could be a divorce. So you just finished your program, and when you came back, your home, your wife is not there anymore. So it is really a terrible situation to deal with. And then you have the maturational crisis, wherein people pass through different developmental stages, wherein you, for example, transitioning from adolescent to adult life could be very stressful to some people. Some people may not at all, but for somebody with other issues, it could be difficult. And in fact, in here, I can I do deal with adolescent crisis also. So sometimes these young people will take time for them to deal with their adolescent crisis, and some of them end up taking alcohol and drugs, and some nowadays self-harming is always seem to be an issue, especially among young adolescents. For the social-cultural aspect, we're dealing with discriminatory practices based on age, race, sex, preference, or class distinction. And of course, we have the natural disasters, medical or mental illness, and SUD. These are the types of crisis situations wherein most people, and especially our people in recovery, encounter in and out of the inpatient settings. It's even more difficult for those who have other issues because they have recurring crisis. Recurring crisis, meaning to say some of them relapse, 3 times relapse, 4 times relapse, 3 times admission. These are but not always because of drugs, maybe because of other reasons. So persons with adequate coping skills are likely to bounce back within their own resources and back to the pre-crisis functioning. However, they may experience difficulty and may resort to substance use or exhibit low moods, irritability, or may isolate, and extreme cases may have suicidal ideation. Then we go to the next slide. Next slide, please. These are the common signs of crisis. No? There are changes in weight, decreased performance school, dramatic shifts in sleeping habits, avoiding social situations, alcohol abuse, sudden changes in moods, neglect of personal hygiene, withdrawal from normal activities, and so on and so forth. There are a lot. These are just the common signs, but there are also other signs that are not listed here. I took this because these are the early sign of crisis happening to a person in recovery. Early intervention is the key to these acute stress reactions and may put their treatment at risk. Hence, the importance of mitigating potential risks and threats to the recovery process. Next slide, please. Next slide, please. Now, crisis, the phases of crisis. Now, this is, I'd like to show you or maybe discuss with you the phases of crisis and how we can detect them. No? So, number one, you have initial threat or triggering event. Most people are faced with problems and conflict that threatens their self-concept. May respond and with this usually you become anxious. And in an effort to lower the anxiety, you may employ some various defense or coping styles, defense mechanisms or coping styles. And you're able to recover from the crisis. And that is because you may have some strong coping skills. So crisis is solved. No, a problem is solved, no crisis. But there are some people who are not so gifted with that. And therefore, we go to number two, escalation. If problem persists, the usual defense mechanisms or coping styles did not work. So what happens? Anxiety levels increases to a serious level because problem solving is unsuccessful. And therefore, the person can experience some kind of extreme discomfort. And then again, you are feeling like disorganized, wherein you have difficulty thinking, sleeping, and doing your usual function. So the lack of success can lead to a sense of helplessness. So for escalation, the thing you should remember is that client experience extreme discomfort that can lead to a sense of helplessness if there is no intervention done. Then we go to number three, crisis happens. You know, in spite of expanding effort to address the escalating discomfort, but all attempts failed, anxiety intensifies to higher levels, to severe levels, and then to panic. And then the person is forced to mobilize his automatic behaviors. Am I going to flight or fight or face the problem? Good if they decide to seek for professional help or talk to a relative, fine. But most will choose not to. So they will definitely deteriorate into personality disorganization. Problem is not resolved in the second and third phase. And even if he has tried to do other things than the usual things that he does, and just realize that they aren't working. Again, anxiety levels become higher and higher and may overwhelm the person and lead to panic and despair, resulting to serious disorganization, depression, and possibly psychotic-like thinking or violence against self or entertaining suicidal ideation, or others may present homicidal behaviors, using transferring their anger and guilt to others. At this point, we need external support that can, help mitigate these things. So we go to the next slide. So this is now the time. Can we move on to the next slide, please? Another one. Next, we skip this. Crisis intervention is the thing we should be doing. This is actually, if you're working in a rehab facility, I think every day we are faced with a crisis. Especially if you're doing in-house work, it's going to be stressful for you also. So what is crisis intervention? Next slide, please. It is an immediate and short-term response to a psychological distress. When we talk of psychological distress, we talk about mental, emotional, physical, and behavioral distress. Practitioners who are doing crisis intervention all agree that before intervening, a full assessment of the individual and the situation must take place. What does that mean? You're not going to do some psychological assessment there. You just need to talk to a client and assess what was happening. So we will go to that into the detail when we discuss about the stages of crisis interventions. We know very well that crisis interventions create opportunities to help individuals develop within the context of the crisis and reduce the risk or impact of the crisis throughout their lives. So crisis intervention is a kind of intervention that we do every day in the center, and you gain mastery by doing this every day if you are in an in-house staff. Let us just remember that when we do crisis intervention, we do not provide the client with solutions. Interventionists only assist in the process of making decisions that lead to the resolution of the crisis. So therefore, crisis intervention is helping client to solve his problem. You're helping him to deal, you're facilitating him, you're helping him deal with it using his own resources. We're just there to assist. We offer help. Okay? What are the goals of intervention? Well, there's another slide. Crisis intervention should be a here and now orientation. What's happening now, you deal with it. It's time limited. You have time limited. If it's a first session thing, you can do 1 hour. But the entire thing of crisis intervention can last from 4 to 6 weeks. It can be a reaction to a stressful situation. And an interventionist assumes an active directive role. So next, please. Next, please. What are the goals of crisis intervention? You stabilizing the symptoms of distress, mitigating symptoms of distress, restoring functional capabilities, and assisting in decision making. So let's just discuss stabilizing symptoms. When we destabilize symptoms, we're talking about de-escalating someone from a crisis. And when we do this, we need to have undivided attention. We have to focus to the client. Eye contact, body language, active listening are very important in this. But please, first tell client, can you please breathe? Let's count 1, 2, 3, 4, 5. I find this very helpful at the escalating clients who are having hyperventilation, who are feeling hyper active and worry and shouting. You just be present and just don't do anything. First thing to do after you make them breathe, you just say, listen. You have just to listen and be present. After that person notices you, that's already a big step for that person. Hey, somebody is willing to listen to me. Because nobody listened to this person, and you're there and you're ready to listen to his story, or just maybe asking him, hey, what's going on? What's wrong? Please be patient. Client may not answer you. In fact, they would push you away and say, and you cannot help me. Nobody ever wanted to help me. But still, being the helper that you are, you can, then suddenly clients cry and say, why are you crying? It's an opportunity to make a connection. And if you go to that 3 levels of communication at the first contact, I think you're going to make a difference in the next sessions. And he says, I've tried everything to deal with this problem, and yet nothing happens. You validate what client says and say, I see, but you can't give up now. You can still try again. Can I help you? Okay? So make them feel that you are concerned about their issues and their well-being, and that they can lean on you for support. Number 1 goal is to help client get stabilized. You need to mitigate symptoms, meaning this is number 2, we reduce the distress being felt by client. You can do that in the different aspects like physical, no, affective, cognitive, environmental, and relational aspects. If you can achieve 3 of this, you can help really mitigate it. How are you going to do the physical? If a patient is in inpatient, that's why we have a closer supervision to those who are still within the 30-day detox, and 30-day 30 days in early recovery up to 90 days. So you need to make them eat. Some don't eat, some don't sleep, because crisis does not happen immediately. It has been brewing for some weeks, and now it just erupted. Person is tired. Person is, have not had lots of sleep, and probably has neglected his personal hygiene. So that's very important that you restore the physical functioning. In the affective, emotional regulation can be an issue here. So maybe talking to client to make him feel, to probably teach him how to tolerate distress, or psychological flexibility by just letting it happen, just noticing the problem and accepting it from where it is. Nothing to do, even if there's nothing to do, but just acknowledging, noticing that the problem is there, and wait for the time when he's ready to deal with it. Environment, keep your environment safe, and they'll probably use positive triggers that can help produce more GABA and serotonin. And I noticed that most SUD who come into treatment would like to have a picture of their girlfriend or of their family or their children. Let them. Or, these things, sort of give them some kind of motivation to, hey, there is a reason to live. There is a reason to go on making myself feel, to make myself, heal and get treatment, and, go through the treatment no matter how difficult it is. So you restore functional capabilities, and if you're successful at engaging client to talk to you, you're able to do number 3. Now you can ask client, how does he plan to address the crisis? What does he want to do? When? How? What are the supports he needs to be able to do that? These things are very important in this, making that person back to the pre-crisis situation. And then fourth, assist in decision making, help client explore the benefits of her chosen alternatives, including the identification of what may not be possible. Now, the stages. No, there are stages. There are only 3 stages here. Next, let's skip that, please. Skip that slide, please. Yeah. There are stages, 3 stages of crisis intervention according to Golan. Assessment, 1 session. That's the first contact. Implementation, 2, 3, 4. That's about 3 sessions. Termination, 5 to 6. 5 to 6. That's 2. That's about, you need to do some, intervention there. For number 1, assessment, session 1. This is the first contact. What are you going to do? No? You have to identify what precipitated the crisis. What is the client's subjective reaction? How did he respond to the crisis? Did he define the crisis? Did he define the context of the crisis situation? Or maybe you can ask, can you remember what started this? And he says, and then you assess client's current state. What's happening now? Precisely define with client, because you're now ready, because he's now engaged with you. This is now your chance to precisely define within client's perspective his current problem and help him sort it out. In other words, it's very important to have that, what we call therapeutic communication and personality, so that you gain the trust and confidence of the client, and that you are there really to help him. So number 2, you have implementation, 2, 3, 4. This is about 3 sessions. So this is now time for you to gather information. What are the information that you need to gather? You need to find out the pre-crisis functioning. What are his coping mechanisms? What are his strengths? What are his weaknesses? Does he have access to support systems? Does he have significant others to support him? Are there organizations that you can tap to help him, access the resources that he needs? And if you have all of these things, you now can have setting, set immediate goals. What are the tasks that he can do? And then how will he be able to achieve his goals? What will be your role and how you can help him achieve the goals? So number 2 is like lots of work, because you need to have more exploration of the available resources, not only external, but also within clients' resources. In here is the stage where you have to do some kind of assessment. That's why it's mentioned here, the strengths and weaknesses of that person, of your client who is in early recovery. In here, in implementation 2, it's very important to coordinate with other clinical staff, so that you will have a very good, repertoire of information about his treatment. So number 3, you have termination. At this point, you have to view client's progress in terms of the goals that he set for himself, and then arrive at the decision to terminate. And then discuss client's plan for the future in relation to his crisis. Because sometimes when you do the treatment plan, we miss to include the we call it the safety plan, a crisis plan, contingency plans if things didn't work the way he planned it. And it's good to do a constant monitoring and evaluation within the 6-week period that he is undergoing crisis intervention. So we go to slide 20. Slide 20, please. Can we just move on? I've discussed some of this. Next, techniques. Next slide, please. Yeah. You see this picture here? This is a person who's listening. Listen first. In fact, all this, catharsis, clarification, suggestion, validation, support of defense, exploration of solutions. If you are in the mental health field, I'm pretty sure you know these things. But one thing that we forget, helpers, sometimes we get to, to be more like conversant, maybe because our clients sometimes are shy, but I urge you to be more of a listener. I found this very helpful. Being a listener, a reflective listener, is so helpful in doing crisis intervention. In fact, the body language makes a lot of difference. A slight detail and no unnecessary movements, and that you're also cool and collected, calm and collected, because it communicates that you are not at all bothered or of his situation. It communicates hope in the client if he sees you very, masterly listening, just listening. You don't even have to talk much, just listen. And with whatever he tells you, that's where you get the information or his sentiments, his problems. That's where you can develop the way to communicate with the client. So in catharsis, we know that we allow the client to release his emotions, release emotions. This can definitely reduce complex feeling. I mean, even us who are not in recovery, when we are able to say what we feel and what we think, we feel good afterwards. So you need to clarify sometimes when they're at the height of a feeling, hyperventilation or panic, what they're saying are not clear. Don't be shy to say, hey, I'm not quite sure if I understood what you are saying. Can you please tell me more about it? It communicates that you are listening to her or to him. And if you have any suggestion, they should be practical and simple and within the context of the client's situation. Um, this is very important because when we give difficult suggestions that would, make them shut up, close their doors, because it will make them. This is quite difficult. That's why I'm having a crisis because I cannot do these things. So we will make it a little bit easier for them. And then validation. Whenever you have an opportunity to affirm or to validate client, do so because it helps him feel hopeful. The word, two words, I see, plus your head tilting a little bit. Acknowledging clients' efforts at dealing with the problem, say, however, you can still try. It may not be time for you now, but maybe next time you can still try. And then supportive defenses. Effective coping strategies is encouraged, especially if he was able to use that in the past and it worked. Using it again may work. And then encourage the increase of self-esteem by regaining the purpose of his existence. Maybe reassure him that things maybe become a little better. By saying that, he will be more confident about his ability, about his capacity, about his capacity as a person to deal with problems. And then, of course, you need to explore solutions, exploring alternatives, and do problem solving with support. When you do problem solving, I suggest that you have to be more solution focused. I think nowadays it has been encouraged. Problems of our SUD is that they find it quite difficult to arrive at a solution to their problems. So I think being solution focused helps also as a therapist or as a counselor. At this point, I'd like to say balancing factors and protective factors. I mentioned it here because in here the importance of therapeutic communication is a key, no, is a key to helping client resolve his crisis. First, next slide, please. Perception of the event, access to situational support, presence of adequate coping skills. These are the three things. How would the event impact client's current status? How would the crisis impact client's current status? If client is in recovery, will it make his recovery more difficult? Or will he more motivated to pursue his recovery? Or what is the meaning of this event to him as an individual? Will it communicate that he's such poor, that he has does not have adequate coping skills, and therefore he needs to have more coping skills training? So it also give us a means to identify an opportunity to identify the limitations of our clients. So next, it's very important also that he is able to access situational support, because no matter how good is your intervention, and if there are no support, emotional support, financial support, or resources, it will be quite difficult for our clients. So we need to coordinate, we need to do case management to be able to deliver this to our client. And three, the presence of adequate coping skills. Person may have to beef up his coping skills through coping skills training. And the more crises that our clients survive, I think they'll be more empowered to go through the recovery, and even post recovery, they'll be better off outside. But we know very well that recovery is a lifetime process, and addiction is a chronic relapsing disease, and therefore our clients will have to like most people, will have to face multiple crises in their lives. But the only way to win is to what? To develop an adequate coping skills, connect with the right people, be vigilant with your recovery, and helping others also in recovery. I mean, sort of help people stay strong. So the keyword that I would like to mention is resilience. That will be the next slide. But then I'd like to summarize this 2 slides or 3 slides by saying that if we did a good crisis intervention, very likely either we make this person achieve a high level of functioning, or he just remain at pre-crisis functioning or lower levels of functioning, which is hopefully not a decline, but we have more opportunity to raise the lower level of functioning to a pre-crisis functioning. That which means we have to work more with this client. So what are the keys to resilience? We need good communication. We need to teach because clients have a difficulty at communicating, especially our SUD. They just numb themselves to their pain and not talk about it. So it's very important to have a clear, consistent information, clarifying crisis events that came in their lives, have an emotional expression with empathic response, promote collaborative decision making. So in here comes problem solving and encouraging resourcefulness. This is stopping the coping, the resources of the client, the internal resources of the client, which we can develop further, and then encourage proactive planning and preparedness. So the reverse of the above may pose risk for maladaptation and may not work for our clients. So in my last slide, I said there is a study titled "The Science of Resilience." What are the ingredients that help people cope? Jennifer Frankl, Feb 18, states that in spite of several evidence that describe the mixed features that bruise resilience. So in other words, there are a lot of studies that on resilience, but in her research, she found out that her study cultivated something that's in short supply these days. And that resilience breeds hope for most people. So, in other words, if you're able to overcome your crisis, rise up above your crisis, and go on with life, you are getting more and more hopeful. So that's it. I think that's all about the crisis. And if you're doing everyday crisis intervention and working in a center, please have some kind of self-care because doing crisis intervention is also causing crisis to the interventionist. And I hope you are also taking care of yourself if you are doing this work. Thank you. And if you have any questions, I'll be glad to answer them.
Thank you very much, Ms. Claire Abbas, for this wonderful presentation with us and with our viewers as well. So, who joined us later, our viewers, I would like to share once again that we have a very special speaker guest who are having very strong academic and strong professional background in substance use prevention and treatment as well. So I would like to just give you a brief introduction once again that Ms. Claire Abbas is a registered psychologist in Philippines. She is an international certified addiction professional, clinical level 2, and he is a master trainer by Colombo Plan Drug Advisory Program for UTCs, and he is also a global master trainer for drug demand reduction by UNODC, and he is also currently he is affiliate to St. Luke's Medical Center Global City as a practicing psychologist for adults clients and doing individual marital counseling or psychotherapy there. She's also dealing addiction. She's also doing addiction counseling for outpatients, including psychological assessment as well. And she's also a consultant psychologist at the Total Care Institute Village in Philippines. This facility is for drug rehabilitation and behavioral disorders, and she's also serving the One Algon Academy, and this facility is for mental health facility. And she also has been to Pakistan through Colombo Plan Drug Advisory Program and UNODC to conduct training programs on basic treatment curriculum, universal treatment curriculums, and refresher course as well. So I would like to now start question and answer session. Can we, Ms. Claire Abbas?
Yeah, sure. I can read, Shahid.
That
Hello.
was a very interesting topic, and that was a very wonderful presentation. So we have received few questions. The first question is received from Dr. Sajid that he's asking what is. Okay, I'm just showing this on the slide. What is an effective approach with substance use dependent adolescents who present in crisis?
Okay. Thank you, Mr. Sajid Aliana, for asking this. An effective approach with substance-dependent adolescents. Well, I find in my work, I'm doing outpatient work with adolescents confronted with co-occurring problems like ADHD. I'm quite happy at they're progressing right now. It's just like, talk therapy helps. Listening, for most part, is very helpful. And empowering him that he is in control of his life. And our role as counselor is to help him, explore his strengths and weaknesses and make good use of them. I won't mention any approach or type of therapy because although there are a lot of approaches, but regular six intervention, counseling session wherein you have a treatment plan and your identified problem and the corresponding intervention that you have to do. I think if you are able to identify the problem, because adolescents are faced with a lot of problem and there's a lot of problems to deal with, and you need to deal the problems one by one, as I am doing right now with my client, and it helps. And another one is that I am quite concerned about is the self-harming behaviors of a lot of adolescents. I think that's a crisis that they are in right now, most of them. And counseling, face-to-face counseling is quite helpful. Talk therapy still helps.
Thank you. I think Dr. Sajid will be satisfied the answer. And now we are taking another question that is from Mr. Shahid Mahmood. He is asking that if police wants to arrest the patient from treatment center, how can we handle this situation? The
Oh, it's
crisis,
a
the realistic crisis.
oh, thank you, Dr. Shahid Mahmood. This is a law enforcement issue and also a treatment center issue. You need to protect your turf. Now, I think you need to sit and talk with the police and with your management, center management. It's quite difficult to be, I mean, everything can be settled by talking and listening to each other's purpose. But if you will to apply the ethics in treatment, I don't know if you've taken up ethics. I think you need to explain to the police the confidentiality of all treatment. And I think that's an issue that you have to raise with the police. And I don't know the laws of the drug laws in Pakistan, but you need to explain to them before they can pull that out. Because, well, if client is at the center, definitely the doctor thought or the doctor believes that he has a drug dependency problem. And when a police comes into the picture, that's a law enforcement issue. And we know very well that they have separate function and they're just wanting to do their job. So you need to sit and talk.
Thank you very much. Thank you. The law enforcement. Yes, we also have to follow our country's law enforcement to deal our clients. So now I'm going to take another question that is from Mr. Aslam. He's asking what actions can be utilized to develop a plan of care that youth will find challenging and worth participating in. Can we?
Okay. This is very, thank you, Mr. Aslam. I think the youth plays a large role in your work in the field of addiction. The young people, the students. I remember the days when I had to do talk in different schools. And one of the things that I like most in helping develop a plan of care of action for the young people is to have a crisis line. This is in line with my topic, crisis line, hope line, whatever you call it. The a call can say answering a call from a crisis-stricken person, and you have the immediate answer can be life-saving. In my time, we were doing crisis line intervention, and we trained young people to be dealing with crisis, para peer group, peer counseling, and it helps. There are a lot of work. plan of care can be done. Access to a helpline can be helpful, and the ones answering are the young people who have, survived their crisis in life, and nothing more can be more emphatic than these young people talking to young people because they speak the same language.
Thank you.
Oh,
And thank you.
it's
Now
okay.
I'm going to because we have a limited time, but we are trying to get benefit from your presence to learn more and
It's
more.
okay.
So,
It's okay. I have all the time for Pakistan.
and thank you. Just 1 hour, 2 questions, and after that we will end our session. Uh, the
Uh,
first, the first one is kindly share few tips about dealing with intoxicated loved ones. That is from Dr. Palat.
Hi, Dr. Talatubi. How are you? It's nice to see you. Thank you for asking question. Well, you were saying kindly share a few tips about dealing with intoxicated loved one. Well, in here, I would probably I would share about my personal thing that my father had issues with alcohol, and I think that's the most difficult challenge to do. Asking him when he's intoxicated, and and you're a young girl, you feel that anything can happen to him. So my mother used to tell him we will leave the house, and because she's so afraid. But then my uncle who's a doctor says, he's a psychiatrist, says, no, don't leave the house, just be present with him. Anyway, he'll be falling asleep afterwards, and he's not causing trouble, and you love your husband. Till my father died, age 62, my mother was beside him, and she did not leave him. And they love each other so much that my mother stayed with him. Um, I think when an intoxicated loved one, for as long as he's not hurting anyone in the family, he will surely sleep afterwards, unless he has other issues. Because in some cases, our loved ones just take alcohol to fall asleep and not cause trouble.
Thank you. Just one more question.
Yes,
That is,
that's more question. Yeah.
just one, only only one. And the question is it possible that crisis intervention can start out of the treatment center? If yes, what are the tools? I'm just showing you on the screen. Yes.
Okay. Um, yes, you can have a crisis intervention. Uh, Crisis intervention can be part of the function of the clinical staff, especially those who had training in doing crisis intervention. Usually, the psychologist or social worker have training psychotrauma intervention. That would be great. And maybe two, when one is not there, there is one who are on call. I think regular in-house training on how to deal with various uh, crises happening in the center, that would be great, and we can save a lot of people from leaving the program early, and we can save crisis happening in the center. So that's also for the safety of the center. If you have one who's very good at crisis intervention, tools,
Thank
you're asking for tools. I think there are a lot of books, especially SAMSA. You have a tip 50, I believe, that you can look into about crisis intervention. And I think also the Colombo Plan has training on crisis intervention and case management. I think those two, UTC, basic UTC, are very helpful. In fact, when I took the crisis intervention and case management, this goes together because you need to tap. resources outside of your center was very helpful in my career.
Thank you very much, Ms. Claire Abbas. Once again, we are also very much thankful to you for sharing your wonderful presentation and answer all of our questions. Um, but because of limited time, I would like to share with our audience that we have limited time, so cannot take all the questions. So if you want to know more about, you can leave your question here, and after the presentation, we will request Miss Clara Abbas to answer your question in the comment box later on when she feel free. As we know, she's having very busy schedule, but we will request request her to answer your question. And I hope that this 1 hour session that would be very helpful for your professional growth. I hope also that all these things you learned from this presentation and from Ms. Clara Bas from Philippines, that you will be implement in your professional and practical life as well. And I would also like to share that this live session has been automatically recorded in 8 channels like ISA Pakistan chapter, Facebook, and Youth Forum Pakistan's Facebook pages, and ISA Pakistan's official Facebook group, Colombo Plan Pakistan's Facebook group, and ISA Pakistan and Youth Forum Pakistan's Twitter and YouTube channels as well. So if you want to see the repeat of this recording, you can go to the channels and YouTube, whatever you want to feel to get easy access. You can see this recording, and you can also share with your friends who are working in substance use treatment and prevention field, and that would be very helpful for those who are working in SUD treatment field as well. So I would also like to share on behalf of ISA Pakistan chapter that all these sessions are hosted by ISA Pakistan chapter, and all these efforts are doing voluntarily by ISA Pakistan, Youth Forum Pakistan, and the entire team of Amajna Foundation. And we are also very much thankful to all our national and international speaker guests who are giving their precious time and sharing their experience and knowledge with our viewers through this platform. So I would like to thankful once again Ms. Clara Bas for your precious time to join us and share your knowledge and experience with our viewers. I hope that is an international webinar, like a live session as well, so more people can see your recording and can join. Yeah. Would
Thank
you like to?
Sama.
Yes.
Yeah, thank you, Sama, for the kind words. I will definitely answer your questions if you can send them to me. And I would like to thank our colleagues, Dr. Talat, and all those who called for giving time to listen to my sharing. And I hope you learned something from it. And I'm always my doors are always open for Pakistan to do something for you. And I'm so glad that you're quite interested and you listen. And I hope we can also listen to you guys. You might have a different story altogether about helping people in the addiction in addiction, and also training addiction professionals, and also of course our our recovering persons who are been there, and I hope some of them some of them probably are your staff. Please share, and please help others to save lives. Thank you very much, Mr. Aslam and Saima and all my friends in Pakistan. I'm so delighted to be part of your advocacy, and my doors are open for you if ever you need some more talks. Thank you very much.
No, thank you very much, Ms. Claire Bas, for your wonderful remarks and wonderful words for all of us and your regard. So I would also like to share that Mr. Robert from Philippines, he's also a very good friend of us, and today he joined us in this live session. Hi, Mr. Robert. Hope you are doing well. And thank you for joining us. Now I'm going to And on behalf of ASA Pakistan chapter, and especially President ASA Pakistan chapter, Mr. Bashir Ahmed Naz, Mr. Aslam he's a advisor and founder Youth Forum Pakistan for Drug Use Prevention, and from the entire Pakistan, we are truly thankful for you, for your precious time, for your wonderful presentation to share with us. And this that was totally voluntarily. I would like to share once again that. And we are feeling very honored to have you with us. That we are also very much aware that you are have a very busy schedule in Philippines.
Not really.
But for your 1 hour and more time, that was very much helpful for all of us. And hope we'll invite you. Maybe we'll get some more time for another topic. So we will invite you with another topic. And till then, take care and see you again in next, inshallah. And also like to, yeah, I would also thankful to all our viewers who joined us, and all our speaker guests, national and international, who served us and contribute for this noble cause to share knowledge, which very much helpful, especially for substance use professionals or treatment professionals, to help and improve our work and improve our services in our facilities as well. So thank you once again, all of you. See you with another topic. Until then, take care and stay safe and be connected. Thank you very much. Pakistan Zindabad.